and anything trait-wise, symptom-wise we see in any character, we can attribute that to grandma. With that third-person perspective that they're all grandma. Just an artistic expression of different aspects of who she is. So mania, impulsivity, drugs, and not only grandma, but any characters demonstrate any signs and symptoms supportive of any of these.
I feel like the lumberjack dude can represent mania, like he sort of went ham among the trees. And like didn't need any sleep, like going on and on. And like very fixated on that one thing.
All right.
The squirrel too, like the assistant reporter, who I guess that would be like substance use, because there was even that like scene, that line where the wolf was like, you should drink less coffee, and he was like, I don't drink any coffee, so like that could be substance use, because he was just so energetic. And
Completely agree. So, and if this were caffeine-induced mental disorder, there are two mental disorders that caffeine can induce. So prep for your boards. What two mental disorders can caffeine induce?
I would guess mania.
It's actually not mania, no. No, stimulants, yes, caffeine, no. Nope. Good news is if you drink as much coffee as you want, you're not gonna become psychotic. Of course, that means that the amount of fluid you ingest is not gonna result in severe hyponatremia, which can induce psychosis. So it's a different mechanism, but not caffeine. Not the direct physiological effect of the caffeine per se. Insomnia is one.
Is that anxiety?
Anxiety is the other. Right? Good. So that's twitchy. Do we see twitchy either not sleeping or appearing slightly anxious? Yeah. That means grandma might actually have a caffeine-induced anxiety disorder, in as much as we think that all of the characters in Hoodwinked are just manifestations of this single character grandma. Any others?
I guess sort of multiple personality disorder with the wolf, like depending how far you want to go with it, sort of putting on different outfits, pretending to be different people, which in the context of an investigative reporter makes a lot of sense, but in the context of sort of it being more in his or her mind, doesn't.
Right. Do we think that if we're formulating the wolf in that context, do we think that grandma actually has a different personality state take over her conscious awareness, or is she still awake and alert and oriented, but assuming a different identity?
The second one.
Okay, so and this is a significant distinction to make clinically as well as in the board exam, right? Because we're talking about the dissociative disorders now. One dissociative disorder is specifically defined through a distinct personality state that takes over grandma's awareness. And the other one is none of that, but that she just assumes a different identity. Now she's a reporter. Right? What are the two conditions that either or both of these describe?
Is the first one DID, dissociative identity disorder?
Right. And that it sounds like the consensus is we're not leaning towards that, we're leaning to the other one, which is what?
you
Yeah, well, more specific.
depersonalization or derealization, dissociation.
Dissociative amnesia with you.
Dissociative.
Now, in either case, DID or dissociative amnesia, there must be element of amnesia. We've got to ask grandma. When we see the scene or a scene with, is it Wolf, W. Wolf? Or, do you recall or recollect what happened, or is there a gap in memory? If she endorses a gap in memory, then we can actually investigate further. Pardon the pun. This may be either DID or dissociative amnesia. And if we don't believe that there's a distinct personality state that takes over grandma's conscious awareness, we're going to say it's dissociative amnesia. And to the extent that she assumes it's different identity as the investigative reporter, dissociative identity with few, excuse me, dissociative amnesia with few. Questions? Any other characters? Personality traits or otherwise symptoms allow us to support one of these diagnoses. It's one more thing. What's going on with that ramp?
So he's blind, so maybe somatiform.
Did he? That's interesting. Is he blind?
It was just sunglasses.
So let's talk about these conditions, because again, it's a great opportunity to review for your shelf exam. The RAM presents the way the RAM presents. As part of their chief complaint, is that there's decreased visual acuity, I can't see. So let's assume that that's the chief complaint. Your workup, including maybe consultation with ophthalmology, reveals that there is no physical basis to support the RAM's chief complaint of not being able to see, right? What's the next thing that comes to mind for a clinician in terms of how to address the answer set A, B, C, and D on the shelf exam? What are you looking for next?
Is there an external motivation to being blind? Because,
Keep that in mind.
okay,
That's next to next.
Is there like a psychological stressor that happened recently?
Potential.
Medical issue?
The answer is no. With that answer, we do have, and the answer is no.
Have they been worked up for this in the past?
The next step in terms of that clinical vignette is whether or not there's any evidence that the RAM is providing you misinformation. Are they lying? Right? Now, if in the absence of any information, we have to assume that the RAM is not lying. Right? So we're always going to give the RAM the benefit. This is a RAM-centric clinical vignette. Right? So in the absence of such information, we have a very straightforward differential diagnosis, and there are two. What are the two conditions? We must now look at choice A and B in that answer set. Conversion disorder or?
somatic symptom disorder.
Perfect, right, perfect. And for this case, which one will it be? And why?
Conversion, right? Because it's a neurological.
Exactly right. Conversion is nothing more than a subset of somatic symptom disorder, the broader illness, in which an individual has one or more somatic symptoms for which no underlying physical cause can be found. When the underlying somatic symptom happens to be voluntary sensory or motor function, we're going to call it conversion. This is conversion disorder. Then we look at the script a little closer. You nerd out. And you look at the script a little closer, and you know what you find? Evidence that the RAM's lying here. Right? Boom, there it is. Now you're considering choices C or D in the answer set on your shelf exam. What are those two choices?
Malingering.
Or- Right. And what will help differentiate, and this is where we get back to the original, I think, observation. I'm sorry, I picked on you with.
All good. If there's any external reward or motivation, like money, fame, etc.
And if there is,
Malingering,
okay, and in the absence,
facetious,
right? That's effective, right?
factitious, yeah.
You'll get it, and you'll read it right on the answers. Right? It's exactly the algorithm I want you to think of. It's very simple. It's a 2x2 reward. Right? Misinformation or not, reward or external incentive or not. Very simple. Right? And I mean, in clinical scenarios, very complex cases, board exams, oversimplified for you. Any idea what's going on with this RAM and their eyesight? Assuming that the veterinarian provided an exam and we're told there is no physical cause to explain the RAM's blindness. Assuming it was blind.
The anticholinergic.
Well, we always have to rule out the direct effects of a substance, no doubt, but we're going to be reassured that there's nothing there. Because if there's any organic cause, medical condition or a substance, no, we have to actually work that out. But in the absence of those, is this conversion or somatic symptom disorder? It's conversion, and so you're right, but that's how we get there. We want to show our work. What's going on with the RAM's thought process?
He's doing like word salad, kind of.
So, any thoughts in terms of supporting? Remember, the RAM's grandma, right? The RAM's presenting signs and symptoms that we're attributing to grandma, the way we formulated this. Any of these initial diagnoses supported by the word salad or flight of ideas? Yeah. So I think the RAM and the lumberjack, symptoms provided, signs provided. Final thoughts on grandma? Grandma's a great teaching tool today. No? Any other characters you want to discuss? Hoodwinked. What's going on with the bunny? Why do you say that?
Well, he lies, and he was basically the one that was stealing the recipes throughout the. whole time.
Spoilers for those following at home. Yeah. So what's the cardinal feature for the antisocial personality disorder?
Pattern of behavior that willfully harms others.
Yeah.
And older than 18.
It's an adult with the hallmark of the blatant disregard for and violation of others' rights. This is the only personality disorder that is an adult only. Every other personality disorder can be diagnosed in children. This is the lone exception. As part of that rule, what must the investigator also seek to determine or support the diagnosis of antisocial personality disorder?
Conduct disorder as a child.
Unfortunately, we don't really get much in terms of past psychiatric history or mental history here. But there does seem to be a blatant disregard for others' rights. Actually, let's talk about the personality disorders in a broader context. There are about 5 signs that we need to actually investigate to further rule in a personality disorder. This cuts across every single personality disorder. What are those common variables that are the common thread for all personality disorders, including antisocial?
Relationships.
So they're clinically significant, right? And disruption or impairment in functioning and interpersonal functioning is but one example, but yes, they're clinically significant. That's definitely one. About 4 or 5 more.
It can't be better explained by like a medical problem.
So just like any other mental disorder, it cannot be attributable to an underlying medical condition.
Like a lifelong pattern of behavior.
Yes, these patterns are stable over the course of development, just like a personality tends to be stable. So yes, there's got to be some stability here. So if we see everyone check the box for every one of the 9 or so signs of antisocial personality, and the behavior started just 2 days ago, be very careful. Right? They may look like the textbook definition, but so it's not a personality disorder, therefore it cannot be antisocial personality disorder. By the way, just to go off on a tangent, what is the most common diagnosis on a shelf when that happens? We see somebody come in presenting with a behavioral change that's abrupt, lasts 48 hours, 72 hours. What are we thinking? What's the
Intoxication, like a drug.
So the drugs have been ruled out. So your intoxicant is
okay.
negative and there's no evidence of drugs.
Psychotic disorder.
So before we say brief psychotic, we have to also think that might be an underlying medical condition.
UTI,
Stroke.
UTI, depending on the age.
So we're thinking delirium. The pattern of behaviors more suggestive of antisocial personality traits. So there's frontal lobe signs, which are progressive in nature.
Frontotemporal dementia,
So more progressive than that,
Lewy body dementia.
more progressive than that.
CJD.
Yeah, so I think instead the biopsy will postmortem will reveal what? Sometimes
Prions.
prions or inclusion bodies. Right, comes up in exams all the time. All right, I digress. So back to our bunny. And back to the general definition of a personality disorder. We have stability, we have not due to an underlying medical condition, and we have clinically significant. What else?
Egosyntonic, so.
Not necessarily. Sometimes people just lack that insight. I know that the board review books love that. Be careful.
Not distressing. It's like it doesn't really cause them like that much distress.
It could cause them significant distress.
Present across like multiple scenarios like school, work, home.
Absolutely. So not only must it be stable over time, but in a slice of time, it crosses multiple settings. Yep.
Unawareness, is that one?
I think an insight. What's the one that always goes with what we had stated already, not due to an underlying medical condition?
Not due to drugs.
Substance, yeah. There's one more. It can't be due to another mental disorder, right? Because if they're manic, And you're seeing the signs and symptoms only during episodes of mania, bipolar 1, not antisocial personality. So those are the actual 5 things that we always look for any personality disorder. All right. Anything else off this bunny? Other characters, Hoodwinked. Red. What'd you say?
She cares a lot about justice.
I wouldn't say she has like a dependent personality disorder, but she definitely bases a lot of her self-worth around her grandmother.
Yeah.
Or like more like actions, I guess, like her grandmother is very important to her.
How about her mom, dad? So a normal person would think little about this in watching this movie. Unfortunately, people around this table are outside the norm. Right? That's called a pertinent negative. If a person maybe doing a psychiatric interview, a psychiatric assessment, spent an hour with you, maybe even more, the duration of this film, and during the initial assessment, never mentions their parents. You can't just assume that's normal, like a writer director just simply not mentioning or casting mom or dad. It's a pertinent negative. So when I hear hypervigilance, when I see this pertinent negative, and when I hear that she's very close to her grandmother, are there some questions you might want to ask her?
Childhood trauma.
Yeah.
Any sort of PTSD symptoms?
Yeah. Absolutely, no doubt here. Again, not saying that Hoodwinked is about PTSD. I'm just saying that if a patient of ours presented with the same things that we're observing in red, the clinician would absolutely ask during the context of the interview. All right. What else about writing?
Keep defined.
I'm not ready to say she has ODD or oppositional defiant disorder, but there's, again, she's precocious. She's not acting like a child, which is part of the hypervigilance. Post-traumatic stress disorder certainly can show up. First of all, what's the cutoff to differentiate from acute stress disorder? 1 month, right? The duration of time of 1 month. So 30, less than 30 days, we're going to call it acute stress disorder. Longer duration than 30 days, we're going to call it PTSD, post-traumatic stress disorder. Otherwise, for all intents and purposes, the signs and symptoms are the same. So let's talk about the signs and symptoms. Usually, and DSM-5 has complicated this just a little bit, but we could work along symptom sets. I heard hypervigilance, so maybe that's arousal criteria. What other arousal criteria are there?
The jumpiness.
Yeah.
Like, if someone slams the door and they just like.
Right, the exaggerated startle. Those are two very common. Unfortunately, in the absence of those two symptoms, the negative predictive value equates to 0. Individuals can still rule in for the arousal criteria in the absence of both hypervigilance and an exaggerated startle. So what are some other signs that you might want to inquire here?
Difficulty sleeping?
Yeah. Right, which is a very common chief complaint. Right? Difficulty concentrating, irritability. The person came in, maybe we'll call her Red, and said, my reason for coming is insomnia. And upon your psychiatric evaluation, you also uncover irritability, affect and affect, type of affect, as well as difficulty concentrating, also part of the routine mental status exam. And you think to inquire, any hypervigilance? Any exaggerated startle response? And the answer is no and no. You're still ruling in. Right. So just a word of caution. Now in exams, the good news is that the exam writers, the question writers usually do put those characteristics in that have us think of PTSD, but we have to, I think in clinical practice especially, realize that the negative predictive value here is 0. Okay. Treatment for PTSD. Very common test question. Which one medication in the acute setting would we want to avoid and why? So psychotropic medication, emergency psychiatry or ER setting, we're gonna want to avoid, because there's more evidence, or there's evidence of adverse outcomes.
The specific drug, or is it like a category?
Category,
Yeah,
yeah, why?
probably heightened risk of substance abuse.
That's true, but let's say in this case, there's not. There's nothing on history, there's no evidence to suggest that red is at risk. So I'm not sure it's true, but we'll say it's true. One of the things that we're very concerned about in settings like this is that benzodiazepines can really affect the integration of the memories. And in the acute setting of PTSD, to prevent those from happening may result in higher risk of PTSD beyond 30 days, but certainly in the subsequent years. Right, so be very careful. It's always good to ground your patient, even if it means talking about what just happened, and avoid the use of medications that can alter or somehow take away from their ability to embed new memories. And the benzos will be at the top of that list. Final thoughts. Hoodwinked. Everybody's talking about the wolf, huh?
Maybe it's grandma's desire to lash out.
Grandma's at the top of everybody's list.
It's just everyone, all the characters are very ironic in the sense that like the wolf is actually the good guy and the bunny is actually the bad guy and everyone's not actually who they seem.
Yeah, definitely a nice little twist on an old tale. Now, Red is not the victim here, and Grandma's not the victim.
I think you could also argue the story is like evidence for why it's important to get collaterals, because everyone's story is different.
Yeah.
I love that idea. And that's a great takeaway message for psychiatrists. Any other thoughts on the wolf?
Question.
We're talking about the wolf and Hoodwinked, and how he really isn't the character we expected him to be, which is a nice teaching point. It's the clinical role in psychiatry, and really any health-related field.
Yeah, I didn't expect him to be like, I guess like a good guy or a neutral person. I feel like I came into the movie with like predetermined associations because of folklore, like he's always a bad. So I did like that they kind of took turns telling everyone's point of view. I just didn't expect any of that.
And that's a major reason why this was assigned. Yep. Let's talk a little bit about this character, and let's kind of take on the same perspective we have for the grandma, and that is the wolf is the only character in this movie. Everybody that we see, every other character we see is a figment of the wolf's imagination. Right? So we're going to go down the same path, albeit briefly, that we did with the grandma.
Of dementia.
So I think that everything we discussed about grandma applies here. Is the reason why you say dementia?
Wolf seems tortured by all the other characters, so there are really no pleasant relationships between Wolf and anyone else in the movie.
Not a large support staff here or support network for the poor wolf.
I think you could go like PTSD again, because I mean, he has sort of a bit of the hypervigilance, but then also he has, assuming that his job is like, he's telling the truth about that. Like as an investigative reporter, you see stuff that could definitely be traumatic, and you spend a lot of your time like lying about who you are on purpose, not for sort of a psychiatric disorder. So I think PTSD would make sense for him.
Affect.
Yeah, flat out.
Yeah. Yeah, I mean, the intensity was certainly at least blunted, if not flat, very restricted range. And I think in the setting of everything that appears to be going on, it's also inappropriate. I'd expect any character, including the one we're focusing on, to have a greater intensity. he seemed to be almost over controlled, right? Anything but weight, the opposite of weight loss, right? Which again is a little unexpected.
Could also be like a sort of trauma response, like he's the wolf, so everyone expects him to be like loud and angry and like vicious. So he like tamps that down to the extreme, so people are less threatened by him.
It kind of reminded me of like, you know, those like like the older black and white detective movies. Like, kind of like a jaded detective, like kind of going along the lines of his job, like what he has to do, he has to like go undercover, get to sleep, like I feel like he's probably done it for so long that maybe he's all kind of like emotioned out, very just jaded.
So what you're telling me is I should have actually assigned this movie along with Seven and compared it to Detective Somerset.
That'd be cool.
It sounds like you just absolutely described Morgan Freeman's character and David Fincher. They're thinking the wrong movie. Yeah, I don't disagree here. That would have been cool in retrospect, maybe next time. Anything else, again, with this idea that every character we see, I mean, are we concerned about visual hallucinations? Visual hallucinations here, simple or complex? Complex, yeah, I mean, I mean, we see them. I mean, we didn't think that they're shadowy or otherwise amorphous. I mean, they have pretty delineated boundaries, and one looks like a ring, the other one looks like red, grandma, bunny rabbit, witchy. All right.
What is it that makes them complex? Like if a patient sees a little girl standing in the corner of a room and that patient.
Complex. Either they're formed or unformed, simple or complex.
So like a simple one would be like, I guess,
Shadow people.
or like auditory hallucinations.
Well, that's hallucination. That's a completely different sensory modality. This pertains to just visual hallucinations. In this case, complex visual hallucinations. Before we reach the conclusion of mania, very similar to what we did or didn't do with grandma. We're thinking of other illnesses that might actually explain this. Anything else you want to know from the wolf here? I mean, and again, the idea here would be, well, you have visual hallucinations. And a very inappropriate affect. There seems to be a significant insight into what he's doing, which is again, a little bit beyond what we would expect, right?
Possibly schizophrenia.
Possibly. Right. So
I'd also want collaterals on him because there's a chance that like you talk to his very hypothetical family members and they'd be like, no, he's not an investigative journalist. Like he just thinks he is. So
that's very fair. Anything else? What happens, and this really would not be really outside of the ordinary for a wolf. What happens if we actually discover that he's got the decreased visual acuity? That is useful, right? Decreased visual acuity, formed or complex visual hallucinations, as well as intact insight.
Because Charles Bonnet syndrome. I know we talked about this morning.
Which is interesting because this movie is about a bonnet, isn't it? Right? It's spelled the same, isn't it?
Yeah.
I think you actually pronounced that. Somebody
I
pronounced that
tried,
bonnet
I
this morning.
said bonnet, yeah, George.
Yeah, it might be a strange case of Charles Bonnet. Right, with that triad, given the wall. Final thoughts. All right, we're gonna end it here. Who's fun? You can title it, Night's Watch. Differential diagnosis.